Hello everyone. It is indeed an honor and a privilege to deliver the keynote address in this Colorectal Cancer Symposium. And I would like to thank the organizing committee and my friend George for this invitation. When we talk about evolution and advances, we must understand that they are two ends of the same spectrum. As Sir Winston Churchill once said, those who fail to learn from history are doomed to repeat it. So we too must understand the historical evolution of colorectal cancer surgery. That brings us to the overview of this talk. I'd like to focus on pre- and post-operative care, operative treatment, selection of treatment, and colorectal cancer training. When I'm talking about operative treatment, I'll talk about the resection, the anastomosis, and about diversion. And in selective treatment, I'll focus on radiotherapy and surgery. Like all other fields of surgery, colorectal surgery had humble beginnings. Before the 20th century, colorectal surgery was characterized by high mortality, largely due to lack of anesthesia and our poor understanding of antisepsis. In the early 1900s, radical colectomies had quite high morbidity and mortality. The 20th century saw advances in anesthesia, antibiotics, and blood transfusions, which made colorectal surgery exponentially safer. Now, these statistics are from an Australian colorectal cancer historical database, and you'll see on the slide in the upper left corner, before the turn of the century, outcomes from colorectal cancer and even simple surgeries like appendicectomy were quite unacceptable by today's standards. In the early 1900s, the outcomes were slightly better, but still unacceptable even from the standpoint of a rural hospital. Which brings me to the first part of today's lecture, which is to reduce the scar of colorectal cancer surgery. Like all other surgeries, colorectal cancer surgery started with open resections. Greater the surgeon, greater the size of the incision. Now there's nothing wrong with open colorectal cancer resections. They have stood the test of time and are still oncologically safe procedures. And for most of us, they are fail-safe. But obviously, there are limitations and there are drawbacks of open surgery, including prolonged hospitalization. Arguably, the biggest development in rectal cancer surgery was the concept of total mesorectal excision, or TME, introduced by Professor Bill Heald in the 80s, which exponentially improved outcomes of rectal cancer resections. This was shortly followed by major trials which validated the place of neoadjuvant therapy in rectal cancer, and the Dutch TME trials, which showed that when appropriately treated, local recurrences can be brought down to less than 10%. Like I said earlier, open colectomy is still widely used worldwide, especially in resource-poor settings, and should not be discounted. Now, I have purposely excluded Kraskay's posterior resection and confined this evolution to start from anterior resection. I feel the posterior resection belongs in a historical masterpiece than as the first step of today's evolution of colorectal cancer surgery. The biggest step in the reduction of morbidity of colorectal cancer surgery and the reduction of the scar size was the introduction of laparoscopic surgery. The first laparoscopic colectomies were performed in the early 1990s by Jacobs et al. And it was immediately obvious that laparoscopy brought advantages like reduced blood loss, shorter hospital stays, and faster recovery. And in addition to all these advantages, we also noticed that there was no increase in complications. And meta-analyses have confirmed that laparoscopic surgery is oncologically safer, if not better, than open resections, especially when it comes to the deep pelvis. You can have slightly better lymph node harvest while there is no compromise to the tumor resection. And the support for laparoscopic surgery grew through multiple randomized trials. The COST trial showed the oncological safety of laparoscopic surgery, while the classic trial showed that there is no increase in recurrence, and the color also showed equivalent survival rates. Laparoscopic colectomy is now the gold standard in most situations, but it has its barriers. There is a steep learning curve and increased cost, especially with the instruments and the laparoscopic stack, and variable adoption and variable availability throughout the world. In almost every outcome you look at, laparoscopic colectomies are superior to open surgery. They have a short hospital stay, shorter duration of ileus, and a lesser degree for analgesia use. Morbidity and mortality are largely comparable. Operative times may be slightly larger, but this is partly due to the learning curve and are becoming less and less. Blood loss is certainly less, and the length of incision is significantly smaller. The next step in this evolution was the introduction of robotic surgery. Laparoscopy has inherent limitations like 2D vision and the use of rigid instruments, which were easily overcome by the introduction of the robot. Robotic surgery brought advances in multiple domains. 3D visualization and the clarity of robotic camera makes visualization, especially deep in the pelvis, much better. Wristed instruments with 7 degrees of freedom of motion makes resections much more precise. And combined with all these advances, improved nerve preservation and better lymph node harvest in rectal resections have been possible. But not everything was smooth sailing. In 2017, the roller trial showed that while robotics offered lower conversion rate and better ergonomics, there was no significant oncological advantage over laparoscopy. And keep in mind, there is a high capital expenditure, nearly 2 million per unit, and a high recurrent expenditure for the instruments. So there is limited access, especially in the low-income countries. Multiple studies have shown that although robotics offer improvements in blood loss, there is no statistically significant difference in lymph node harvest. And in certain studies, robotics take longer than standard laparoscopic surgery. There are also statistically significant advantages in terms of recovery of bowel function and the hospital stay in using robotic surgery for colorectal cancer resections. Compared to laparoscopic surgery, there is no difference in complications like ureteric injury, conversion, or anastomotic leak. The next step in this evolution of robotic surgery was the introduction of the single port robot, or the Da Vinci SP, which made the incision even smaller. Now, I'm not sure whether the Da Vinci SP has been licensed in the US, but I was fortunate to watch this surgery in South Korea, and it is truly inspirational. Another option to reduce the morbidity of the surgical incision is the use of natural orifice specimen extraction. Now, I must confess that I do not use this for my colorectal surgery, but there is enough evidence to support the safety of this process. On this topic of wristed instruments and the advantages they bring, especially in a narrow male pelvis, I'll be failing in my task if I don't talk about articulated laparoscopic instruments, or what the company used to call human-powered robot. Art Essential is my favorite articulated instruments, and it is truly a marvel. It gives you robotic-like access in your surgeries for, I guess, less than 1/100th of the cost. This is not without limitation. The first generation of Art Essential uses an 8 mm instrument through a 10 mm channel, which increases your carbon dioxide leak and makes surgery slightly more difficult. But the Gen 2 uses 5 mm trocars, so overcomes this problem. Though the company says these are single use, I have comfortably reused them, and I am impressed by this device to no end. Another development in the minimally invasive colorectal cancer surgery was the introduction of TAR-TME. I was very lucky to have the opportunity to learn TAR-TME from one of the masters of this surgery, Mr. Janindra Varusivithana, a surgeon at St. Mark's Hospital, London. He is the gentleman in the picture in the right upper corner. Oops, that's the wrong picture. And St. Mark's Hospital was also where I met my dear friend George for the first time. Multiple randomized trials have shown the safety of TAR-TME and the comparable oncological outcomes. The biggest advantage of TAR-TME for colorectal surgery is the access it brings. With superior visualization, especially for colorectal cancers, and improved ergonomics for resection, TAR-TME reduces the CRM involvement and has comparable incompleteness of TME and anastomotic leak rates. I would now like to focus on a completely different domain, and that is how to avoid surgery. Now, I don't think we ever thought that a surgeon would talk about avoiding surgery for rectal cancer 20 years ago. But here we are. Watchful waiting for rectal cancer surgery has caught on. Initially introduced by Habragama, now with multiple randomized trials, there is sufficient data to show that although there is an increase in local recurrence, there is no change in distant metastasis and cancer-related deaths. The 2-year, 3-year, and 5-year disease-free survival and overall survival are largely comparable to surgical resection. The biggest paradigm change in our thinking about colorectal surgery, I feel, comes in the direction of leaving less tumor behind. And I'm referring to CME, CVL, and D3 lymph node dissections. Central vascular ligation advocates division of the supplying blood vessel at its origin. And this is largely to get to the D3 lymph node in your surgical specimen. Like the D3 lymphadenectomy popularized by the Japanese for gastric and esophageal cancer, D3 has made its way now to colonic cancer. This is especially relevant for right colon cancer resections because we often leave the mesenteric sail behind. So we need to achieve a D3 lymphadenectomy through central vascular ligation in colonic cancer resections. I'm sure all of you know about the colon lymph node stations. I have only put this to illustrate my point. The picture of the specimen was a patient who underwent a subtotal colectomy or synchronous colorectal cancer, and you can see the mesentery has been resected up to the SMA. The next part of this trifecta is the complete mesocolic excision. This mesocolic plane is very clearly visible laparoscopically, and I would like to direct you to this excellent paper from some of my friends at St. Mark's, which shows you the embryological basis and histological evidence for this mesocolic plane. In the search for more radical resection and leaving less tumor behind, we saw an introduction of lateral pelvic lymph node dissection. I personally don't practice this, but I was fortunate to learn this from, I believe, one of the masters of lateral pelvic lymph node dissections, Professor Yoon Suk Lee at Seoul St. Mary's Hospital. And robotic lateral pelvic lymph node dissection basically skeletonizes every vessel in the lateral pelvic wall to remove all the lymph nodes. Unlike other surgical procedures, this has limited evidence, most likely because very few surgeons practice this. And for now, we need to keep in mind that lateral pelvic lymph node dissections increase the overall complication rate and urinary dysfunction, while there is no statistically significant increase in anastomotic leak, and there is no difference in distant metastasis and local recurrence. The most dreaded complication for any colorectal surgeon is an anastomotic leak. So let's look at how we can reduce our anastomotic leak rate. First, we must make sure our anastomoses are well perfused. And ICG is a very good tool to assess bowel perfusion. Multiple studies have shown that ICG assessment of bowel perfusion reduces anastomotic leak and reduces the reoperation rate. Keep in mind, if you don't have ICG, the easiest thing to do would be to check the perfusion of the marginal artery before ligating it. The use of a powered circular stapler has now been shown to reduce the anastomotic leak rate as well as anastomotic bleeding. There are multiple theories behind this. One is the use of 3D staplers, and the second is the use of a different gripping surface to minimize tissue migration during stapling. I personally don't have any experience with the use of a 3-row manual circular stapler, but studies show that this too can reduce the anastomotic leak rate, although it has no effect on anastomotic bleeding. Some surgeons believe that most anastomotic leaks happen at the dog ears of the transverse stapler line because they become ischemic. And techniques of avoiding dog ears in an anastomosis have been introduced. Now, this paper states that the avoidance of dog ears by suturing them uh, reduces the anastomotic leak rate by about third. For difficult low rectal resections, there is also another technique that you can use. You can use a double purse string, single stapled anastomosis. How the purse strings can be put varies. You can either do it laparoscopically, like in this picture, or you can place the purse string transanally with the use of a Lone Star retractor as shown in this picture. The next area I would like to focus on includes reducing the morbidity, especially of neoadjuvant and adjuvant therapy for rectal cancer. As surgeons, we all have seen the side effects of chemoradiotherapy. The Mercury 2 trial showed that the use of MRI could identify low and high risk patients for the development of local recurrence and metastasis, and thereby could guide us in selective chemoradiotherapy in rectal cancer. There is a growing body of literature to support the use of intraoperative radiotherapy for rectal cancer. This was a paper by a friend, Mr. Reza Nizami, which showed that intraoperative radiotherapy reduces 5-year local recurrence and improves disease-free survival and overall survival while not increasing any complications. A discussion on the evolution and advances of colorectal surgery would not be complete without the mention of the enhanced recovery pathway. ERAS is not new, and I don't think there's anything new that has happened in ERAS in the last decade, but it is still important to adhere when you're doing colorectal surgery. Adopting an ERAS pathway for your colorectal cancer patients will bring several benefits, including reduced overall morbidity, reduced surgical and non-surgical complications. These include cardiovascular and respiratory complications, as well as a shorter length of stay and reduced readmissions. When you talk to patients, you will realize that the biggest worry they have when they're coming to meet a colorectal surgeon is whether they will require a stoma. So I would like to focus on minimizing stoma use in colorectal cancer surgery. Although this study was a retrospective review, they looked at protective ileostomies, transanal tubes, and no protection for low rectal cancer resections. And they found that a transanal tube was equally protective of an anastomosis as an ileostomy. So this might be a good option for us to reduce our ileostomy rates. Next, I would like to focus on something that is very close to my heart, and that is colorectal surgery training. How do we make less errors during our surgeries? Remember, a lot of the problems of surgical training comes in the era of laparoscopic surgery, and that is because of the inherent limitations of laparoscopy, like 2D vision, the fulcrum effect, and the loss of depth perception. So trainees require more time and more training opportunities to reach their performance levels. If you look at the evidence for training and learning curves, it takes between 4 and 5 sessions for trainees to reach a plateau of 80% for medium complexity tasks. And beyond 5 sessions, some students could reach levels of 96% of the desired level. And when we look at simulation-based mastery learning, this approach makes trainees perform faster, their operative performance scores are better, their interruptive complications like peritoneal tears and conversions were less. Now this was a study for TEP hernias. Postoperative complications like urinary retention and seromas were less, and the need for overnight stay was less, meaning all potential outcomes, intraoperative and postoperative, can be improved with a mastery learning approach and simulation-based training. And the authors beautifully showed that when you take some participants from the control group and introduce them to simulation-based mastery learning, they immediately come to the level of the intervention cohort. For anybody who's interested in this area, I'd like to direct you to this book, Heat, by Anders Ericsson, who introduced the concept of deliberate practice and the 10,000 hour rule, which I feel has a big potential to revolutionize surgical training. And I have been focusing on this as a part of my PhD to improve simulation-based surgical training. Can everyone become a master surgeon? Well, the evidence says no. This study, which looked at the aptitude using visuospatial ability, depth perception, and psychomotor ability, divided surgeons to high aptitude and low aptitude. Those who belonged to the high aptitude group achieved proficiency after a mean of 7 attempts at training, and this ranged from 4 to 10. The group that was called low aptitude, only 30% achieved proficiency after a mean of 14 attempts, which ranged between 10 and 16. 40% showed some improvement but did not reach proficiency, and 30% failed to progress. And this is something we need to keep in mind, especially as trainers and program directors when assessing our trainees. So you can see in this evolution and advance of colorectal cancer surgery, getting better means getting less. We want to scar less, we want to cut less, we want to leave less, we want to leak less, we want to hurt less, we want to stoma less, and we want to error less. And that brings me to the end of my lecture. I would like to thank the organizing committee and my friend George for this generous invitation. And I would like to thank all of you for your patient attention. I am an academic surgeon in Sri Lanka, which is a tiny island in the Indian Ocean. If anybody has not been to Sri Lanka, you don't know what you're missing, and I would like to extend a warm invitation for all of you to visit us. We have our annual academic sessions in September, so that might be a good time to come and see us. Thank you again.